as for consumers. Q14 Do you think the National Medical Commission Bill 2017 will be able to provide a dynamic new thrust to medical care in India? Critically comment. 250 words. The Hindu background. The National Medical Commission Bill is the product of the NIDIA fog and was drafted following a scathing Standing Committee report in 2016 on the corrupt functioning of the Medical Council of India (MCI). www.insightsinIndia.com 59 www.insightsays.com. The bill, if passed, would repeal the Indian Medical Council Act, 1956. It provides a new thrust to medical care. The bill seeks to regulate medical education and practice in India. The bill attempts to tackle two main things on quality and quantity: corruption in medical education and shortage of medical professionals. The bill aims to overhaul the corrupt and inefficient Medical Council of India, which regulates medical education and practice, and replace with National Medical Commission. The National Medical Commission would be an umbrella body for supervision of medical education and oversight of medical practice. Entry test. It replaces multiple MBBS entrance exams conducted by state universities, thus providing a level playing field to aspirants across the board irrespective of educational or social background. There will be a uniform national eligibility code entrance test meet for admission to undergraduate medical education in all medical institutions governed by the bill. Exit test. In the light of management quota seats in private medical colleges and quality of medical professionals deteriorating, there will be a national licentiate examination for the students graduating from medical institutions to obtain the license for practice. This examination will also serve as the basis for admission into postgraduate courses at medical institutions. There will also be a medical assessment and rating board which will grant permissions for new colleges and penalize institutions which don't follow the prescribed standards. It replaces multiple MBBS entrance exams conducted by state universities, thus providing a level playing field to aspirants across the board irrespective of educational or social background. It mainly focuses on outcome-based monitoring, which was neglected before. Concerns. One of its goals is to rein in corruption in the MCI through greater distribution of powers. This is to be accomplished through an independent medical advisory council to oversee the National Medical Commission, which is the proposed successor of the MCI. But all members of the NMC are members of the council, undermining the latter's independence. A bridge course allowing alternative medicine practitioners to prescribe modern drugs is mentioned in the bill. Unscientific mixing of systems and empowering of other practitioners through bridge courses will only pave the way for substandard doctors and substandard medical practice. This will seriously impact patient care and patient safety. Indian Medical Association IMA opposed the bill that it will cripple the functioning of medical professionals by making them completely answerable to the bureaucracy and non-medical administrators. NMC will become subservient to the health ministry, given that the representation of the medical profession in the new regulatory framework is minimal. The bill allows private medical colleges to charge at will, nullifying whatever solace the needs brought. The private medical colleges will be allowed to decide the fee for 60% of their seats, while previously it was 15%. This will increase the cost of medical education. The proposed NMC bill discreetly intends to equate the postgraduate degrees given by MCI or proposed NMC and the National Board of Examination North by East, which is unjustified. To the fundamental flaw in the proposed medical commission is the lack of clarity on its function. The commission as a regulatory body can be expected to monitor and regulate the training of healthcare personnel and maintain professional standards, and not to formulate policy. It is unhealthy to have an almost entirely nominated commission as the present bill recommends. The proposed NMC has no mechanism to prevent the situation when medical colleges' recognition is withdrawn and students' future is hanging in balance. It would replace an elected body, Medical Council of India, MCI, with one where representatives are nominated. The nexus between the unqualified practitioners or RMPs, rural not registered medical practitioner, is apparent, but bill neglects this. www.insightsinIndia.com 60 www.insightsays.com. There are apprehensions whether allopathic or AYUSH doctors will be willing to work in villages. The NMC bill misses an opportunity to plant for India's rural health care needs in the coming decades. It eases regulations to set up private medical colleges, a move that will hopefully produce more doctors, This measure isn't enough as there is a severe shortage of doctors and most of them are concentrated in urban regions while close to 70% of Indians live in rural provinces. Due to this, rural people rely on informal healthcare providers training non-doctors. The focus is still largely on RBB's doctors as the best means of healthcare delivery in isolated parts of rural India, ignoring the evidence from countries like Mozambique and Thailand which show that training non-doctors can be a safe, effective and cheap way to provide life-saving healthcare when no doctors are available. It will cripple the functioning of medical professionals by making them completely answerable to the bureaucracy and non-medical administrators. Suggestion: to bolster healthcare delivery, there can be a 3-year diploma for rural medical care providers, along the lines of the licentiate medical practitioners who practiced in India before 1946. NMC should open gates to overseas doctors to regularly practice medicine or perform surgery without qualifying the national licentiate examination or induct AIOSH colleagues without clearing next. Also, the accreditation and rating function of the Medical Assessment and Rating Board, the MARB, should be out of the ambit of NMC. This was also the recommendation of the Parliamentary Committee report in March 2016. Clear guidelines are required indicating the circumstances and diseases where traditional practitioners can prescribe allopathic medicines. Community-level accredited practitioners after training should be equipped to provide the first line of care for acute conditions and to make referrals to a regular doctor within a GPS-supervised system. A new system of community-based trained health workers, not government employees, who are enrolled on the state medical register is needed. This can only be done if the medical education law provides for it. The new bill should promote integrated medicine, enabling people to access multiple choices but available under one roof, particularly for chronic conditions. The bill does not address how India would produce enough competent doctors to meet its evolving healthcare challenges and how can it minimize opportunities for rent-seeking in medical education and practice. There is a need for more elected members in the commission, but with limited terms of office, so that corrupt members aren't re-elected. International example: there is a need to keep the NMC free from political influence is for an independent body like the Union Public Service Commission to select its members. Such a model is followed in the U.K., where the Professional Standards Authority oversees the selection of members to the General Medical Council. Conclusion: the bill needs to confront reality and address it, keeping consumers